So let's talk about bariatric surgery. So what's bariatric surgery for?
Weight loss.
Yeah, so it's weight loss. There's certain criteria. So how do we measure somebody's like weight?
BMI.
More specifically, yeah, so more specifically. So there's BMI, but then to be covered by like your insurance, you have to meet other, typically, I don't know if things have changed because I haven't done it since residency, but typically you had to have like 2 or more other comorbidities because of it. Mm-hmm. So what do you think would be like an example of that?
Like diabetes.
Exactly, perfect, that's a great one. So diabetes, like hypertension, maybe like obstructive sleep apnea, any of these things that are compounded by that. So what are the different types of bariatric surgeries?
So you can do a gastric sleeve.
Yeah, so let's go simple first, okay? So here's your esophagus and here's your stomach. This is the greater curve, this is the lesser curve of the stomach. And then this is the duodenum. So here's your stomach, and this is the start of your duodenum. And then what's this like that separates the two?
The junction.
There's like a valve.
The
pylorus.
Oh yeah, the pylorus.
So the pylorus is here. What's a common thing in pediatric patients that they can get? Not common, but yeah, pyloric stenosis, where you have to go in and actually release that. So that's an interesting, just side note. So you said a sleeve. So that tends to be nowadays the most common. So what we'll do is we'll put a large caliber bougie down here, okay? And then we'll use a GIA. I talk about the staplers all the time. You used one on Saturday. So a gastrointestinal anastomosis stapler. That's going to throw 2 lines of staples on either side like this, and then it's going to cut in the center. And so what you're going to do is you're literally going to take that stapler, the bougie's there to protect this area, and then you're literally going to do, this part of the stomach's going to be gone. Sleeve gastrectomy. So it's more of what we would call restrictive, because you just now can't put a large food bolus or volume of food in there, okay? Then we're dealing with a patient right now that had a, what's the other one?
Roux-en-Y.
Yeah, so like what's called a gastric bypass. And so we call those a Roux-en-Y. Do you know how the anatomy works for this one? Because this gets very tricky.
I know they bypass the stomach by attaching it to the duodenum.
Okay.
The second part of the duodenum, but then they also attach the common bile duct also has to be.
So you don't touch that. Don't touch the common bile duct, because that's, you're just messing around with the alimentary canal, if you will.
Okay.
Okay. So a Roux-en-Y gastric bypass is a challenging procedure. So we transect the stomach essentially, creating a pouch. So that has the same similar concept of that idea of restrictive, okay? So then we need to perform a GJ. So this is your stomach, gastric, so G. This is your your duodenum, and then this is J. This is your jejunum, okay? So you have to perform a GJ anastomosis, okay? And then though you have this, what we would call then, so this is transected here. So now what you were describing, you have your pancreas here, okay? And then you have your liver here with your gallbladder. Typically we take their gallbladder out during this procedure. And then you have your cystic duct and then making your common bile duct coming here. So then this is called your what?
The sphincter of Oddi.
Yeah, sphincter of Oddi or ampulla of Vater. And so this is dumping bile and digestive enzymes from the pancreas into this limb. So then you have to reconnect this limb to here. So you're ending up with a GJ and then a JJ anastomosis, and then distal to that is what you described as the common channel. So typically it's 50 centimeters and then 150 centimeters and then the remainder of your bowel. So this not only is restrictive, because now your stomach is only here, but then it's causing malabsorption as well. So this is typically reserved for patients that have super high BMIs, not so much the sleeve for that patient population, where this works better because it's both restrictive and malabsorptive. But these can cause all sorts of problems, because then you have your transverse colon coming across here like this, and depending on how this reconstruction is done, back in the day we used to go retrocolic. So we would make a rent in the mesentery here and pull up this J through this for the GJ. But that rent in the mesentery could then cause an internal hernia. And there's a specific name for that type.
Starts with a P.
Yeah, Peterson's. This is a Peterson's defect causing an internal hernia. Or you can get a band adhesion or any sorts of other problems. So this doesn't come without its, multitude of issues. Sleeve, where most common complication or concern always is for a leak, because again, it's a staple line. But then in this, you have multiple anastomoses, so you're also very concerned about a leak as well. Does that make sense? This is that's a tricky one.